Hello everybody and welcome to the Hughes Clues chest tube. I have to start out with a disclaimer that there is a chest tube document that can be found in the clinical packet somewhere in the course notes. And this document was originally created by Carol Harbor, a former UTA instructor. And it's, of course, a Word document, so it's kind of dry just to read it. And so that's why I've created this presentation using that document. I've deleted some things, moved some things around. I never know what you're going to be asked about, but I really believe that what I have is the information you need to know. But for those inquiring minds, just look at that original clinical packet document or course document to make sure you have all of the nitty-gritty details. Now, chest tubes can be a little bit confusing, and so I'm going to start out with an A&P review, because if you don't understand the anatomy, then it's not going to make sense on how you need to manage the chest tube. So all of this information, I kind of used this YouTube video. It's, I think, 15, maybe 20 minutes max in length. So if you want, you can go ahead and read or listen to this video also, in your spare time. The interior of the thoracic cavity, so that's what we're talking about. We're talking about the lungs, and the thoracic cavity has three separate spaces. So you got to think about them as three separate rooms, because if you have a problem on the right side, it doesn't really conflict the left side for the most part, because it's a separate space. So you've got the right lung cavity, the left lung cavity, and then this space right here is identified as the mediastinum. And of course, in this picture, you don't see anything there, but that's where the heart and great vessels are. So yeah, it's an important space. The diaphragm, which is not in this picture, is a muscle that extends all the way across on the lower boundary of the thoracic cavity. Now, the rib cage, which you can see here, is lined by the parietal pleura, and then the lung is covered by the visceral pleura, which is really what this blue lining is meant to indicate, the visceral pleural. It's also called the pulmonary pleural. Who cares? Most of us know it as the visceral pleura. So the visceral and the parietal pleura, they're in close contact with each other, but they are separated by a thin amount of pleural fluid, and that's usually about 50 mils. And so the pleural fluid has two great things to do, and that's allowing the pleura, the visceral and the parietal, to stay in close contact with each other, but also it allows them to slide over each other as the lungs inhale and exhale, so as breathing is done. Now, as I said, the parietal and visceral pleura stay in close contact to each other as long as there's negative pressure in intrathoracic cavity. So negative pressure must exist for those two spaces, or those two cavities, for those two pleural pieces to stay together. And the amount of intrathoracic negative pressure will change during breathing. So when you look here, you can see the process of inspiration requires that the diaphragm drops down. I know this isn't a really pretty picture, but that's why it's kind of below the play line on that video. And then the chest muscles and the intercostal muscles are what allows the chest to kind of puff up and out. And so what this purpose of this is, it increases the space and therefore increases the negative pressure. So you have -8. And then during exhalation, when everything kind of just goes back and relaxes, the space becomes smaller and the negative intrathoracic cavity is less than what it was on inhalation. But what you need to identify is that it's always negative, as opposed to outside atmospheric air, which is considered to be at 0. This is a physics thing. It's not necessary that you know these numbers, but you need to just get that it's negative pressure and atmosphere is 0. Now, when air and fluid collect, air, blood, or fluid, collect between those two pleural linings, so between the visceral and the parietal lining, then now there is a space that's created. and it separates the pleural from the visceral pleura, and that's not a good thing. And the normally negative pressure, when this space is created, is disruptive. And because there's no longer this negative pressure, or there's less negative pressure than what there was, it can cause the lungs to either partially or completely collapse. Again, if it's happening on the right side, then it's going to affect the right lung. It's not going to affect the left lung initially. Now, what I want you to know is that just like all things in the body, there's only so much space. And if you have a bunch of air or fluid that is in this pleural space, it's going to take up the space that the lung should occupy. And as more and more and more blood, it's usually air, if it's air that collects, then what's going to happen is it's going to start pushing the right lung over to the left side. And because the mediastinum is smack dab in the middle, it's going to start pushing the heart and the great vessels over. And so this is a problem because it's going to create a critical situation, a life-threatening situation, and that is known as a tension pneumothorax. So now we're really going to get into what you have to know as far as for testing purposes, because this is what you're going to be tested on. The A&P was really to help your understanding. So what is the purpose of a chest tube? Well, if there's air, blood, or fluid in that pleural space, or even in the mediastinal area, we need to get it out, because again, if the air, blood, or fluid is taking up the space, that means the lung is either partially collapsed or completely collapsed, and that means that the lung cannot inflate and collect O2 or use the O2 that should be in there. So that's the reason why it is a critical situation. And then a chest tube is put in also because just because a patient gets a pneumothorax or a hemothorax or collects blood or fluid or air in that space doesn't mean that it's going to be a one and done thing. No, the problem can remain with the patient. And so we have to get rid of it and keep it away. And then in addition, if the underlying problem was caused because of lung tissue damage, then the chest tube will be there to keep the patient stable while the lung tissue or parenchyma heals. Again, that chest tube is there to remove the air, fluid, blood that's not supposed to be there, and then reestablish that negative intrapleural pressure, which will allow the lung to reinflate and allow those pleural linings to become. So again, this is very important. Now, the mediastinal area, as I stated, was a separate space than the lung, the right and the left lung. And so part of it is a little bit different. And so we're going to talk about that at the very end of this presentation. For right now, let's just talk about the lung and why are chest tubes placed in the lung spaces, either right or left. And the reasons are here listed: pneumothorax, hemothorax, pleural effusion, empyema, and chylothorax. And then again, the mediastinal tubes are placed to prevent cardiac tamponade post-cardiac surgery, as stated. More on that later. So let's talk about each one of the lung issues, and we talk first about pneumo. Just like the lung sound or the name sounds, pneumo means air, thorax in the chest. And it's probably the most common complication or problem that occurs that's going to require a chest tube. Now, I've got a picture of a tire, a bicycle tire here, to kind of, for those people that really need something concrete and something they know to understand this, you have to realize that the lungs have an inner tube, which is like the tire, and then they have the outer tube, which is the external chest wall. And one or both of the inner or outer tubes can be punctured. So if you're going, again, we're talking about pneumothorax. If we're talking about a pneumothorax, it can occur if there is an external puncture of a hole in the chest. And this is usually occurs because of trauma from a knife or a gunshot wound, or if the person has a car accident and they ram their chest to the steering wheel and there's no airbag, then they can get a disruption in the outer wall. A thoracotomy, know that word, is what happens when an individual needs surgery within the chest. And so thoracotomy is the incision that the physician will make to open up the chest wall. And then also procedures such as a central line placement can cause a pneumothorax. And let me explain a little bit about this, because a lot of students are unsure, how does that happen? And if you look at this diagram, you can see that here's the subclavian. So it most often a pneumothorax will occur with the subclavian, though if you have a really inexperienced physician, if they do the internal jugular, I guess it's possible to cause a pneumothorax, not as likely as it is. So you can see here with this picture that the individual putting the subclavian line in, or central line using the subclavian vein, is going to stick that subclavian vein with a needle. And if they go a little bit aggressively and that needle goes through the front wall of the vein and then goes out the back wall, it's not pictured here, but right here, very close to the subclavian vein, is a thoracic cavity. And so that's how a pneumo can occur. The other cause of a pneumothorax from an external air entering or external puncture of the outside wall of the chest could be some kind of invasive pulmonary procedures. Now, also the interior wall, so that would be the inner tube, so again, think lung, that the lung can also be punctured. And this can happen spontaneously from some individuals. Let's say it's Dirk Nowitzki, he's about 7 feet. They have a tendency to have thinner lungs because they're obviously bigger for their height, and so they can have a spontaneous pneumothorax. Patients with COPD have poor lung tissue also because they're markedly inflated from the retention of CO2. That can cause a spontaneous pneumothorax. And then if you think back to Tony Romo several years back when he was a quarterback for the Dallas Cowboys, he had a blow to his chest and then a rib that actually fractured and then punctured the lung and damaged the lung, and he had a small pneumothorax also. Again, what's the problem with the pneumothorax? Well, just like it sounds, air collects in the pleural, it takes up space, and it disrupts the normal negative intrathoracic pressure, and this will require a chest tube. Now, here are some other examples of causes or problems that would require a chest tube, and I'm going to let you just go down the list. You can see that a hemothorax, that would be blood in the pleural space. A pleural effusion means that there is a collection of fluid. Serous fluid is usually lymph fluid, and that can occur from CHF surgery or malignancies. Now, I do want to note some terms because this is what students commonly get confused on. What is pleurisy? Now, you guys know, well, PLEUR is going to be something to do with the lung, but pleurisy is the same thing as pleuritis, and that's simply inflammation. Now, inflammation or pleurisy or pleuritis can lead to a pleural effusion, but pleurisy in and of itself is not needed, or a chest tube is not needed for pleurisy. A chest tube would be needed if the pleurisy caused a pleural effusion, a lot of fluid that collects in the lung. Chylothorax is lymphatic fluid. Empyema is pus. Again, read these for the details. So let's do a case scenario, because as a nurse, really pretty much what you're going to be asked about, not only in the critical care exams, but also on NCLEX and your ATI assessment, is what's the nurse's role? How do you assess or determine that a problem occurs, and what are some complications that can be found? So let's say you have a patient who's in the emergency department and they tell you that a day ago or yesterday they were tackled on the football field, and then the patient states he received a forceful blow to the side of the chest while he was tackled by the opposing team member. Again, this is the Tony Romo scenario. So what I want you to do is think about what would the initial complaints or assessments would lead you to suspect a pneumothorax, and then if you do suspect a pneumothorax, what complications can occur? In other words, what would suspect of the most lethal complication, which is a tension pneumothorax. So let's look at the first thing, what assessments? And so the patients are likely to complain of chest pain, especially if the lung is partially or totally collapsed, or just because if you get hit pretty hard from a football player or soccer player, it's going to hurt. But they may also complain of shortness of breath. Their oxygen saturation may be decreased depending on the lung, if it's collapsed partially or totally, and how much of a reserve they have. If it's a 10-year-old, they may do well. If it's an 80-year-old, not so well. Now, one key assessment is if your patient has a pneumothorax, they will have unequal breath sounds. Is this always the case? Well, probably not in real world, but we're talking testing world here. And how does an examiner pinpoint or identify to you or kind of make you suspect a pneumothorax? It's going to be unequal breath sounds. If your patient has a right pneumothorax, they'll be diminished on the right side or absent breath sounds on the right side. Subcutaneous air can be present. Subcutaneous air is also called subcu air or crepitus. And so if you think about it, if you look at this scenario here, if there's air in the pleural space, it can kind of leach out into the subcutaneous air or the soft tissue under the skin. I've seen this lots and lots of times. I don't understand the physics to it. I don't even know the physics to it because I don't care. If you're an inquiring mind, that's something you'll just have to look up. But be aware that if you see, you're not going to necessarily see it, but if you identify subcutaneous air, you better think pneumothorax. What would it feel like, or what would lead you to the suspicion that your patient has subcutaneous air? Well, you're going to palpate the chest surface as part of your assessment. Not only are you going to hear or listen, but you're going to palpate. And some describe it as feeling like a sponge. I don't agree with that. It doesn't feel like a sponge to me, and I felt several instances of subcutaneous emphysema. I really feel like it is more if you were to put Rice Krispies cereal in a baggie, fill the baggie with some air, and then touch the baggie with a layer of rubber on top of it. That's what subcutaneous air. You can't hear the crackle, but you actually feel it. It's kind of like you feel this kind of popping. You don't hear it. I guess you could if you put your stethoscope on it, but you feel this popping as when you ever touching air, it kind of displaces. To me, it's kind of like small bubble wrap. Now, if the subcutaneous air is enough of it has been leached out, then it can move up into the neck area. I had a patient that this happened to, and the reason why they came into the hospital is, yeah, they were in a lot of pain. But more so, their wife made them come in because their voice sounded very muffled. And that's because you've got this air that's taking up space alongside the trachea or the pharynx, and so it's kind of pushing the voice box, and so that's why their voice was muffled. The physician's going to order an x-ray, or I should say healthcare provider, because it could be a nurse practitioner. And then this represents, this really scenario that I've given you represents a pneumothorax. If the patient had a hemothorax or any kind of other fluid field, such as I just almost said pleurisy or pleuritis, but that's not pleural effusion, or a chylothorax or an empyema, you would have the unequal breath sounds, but only if they have a pneumothorax are you going to get the subcutaneous emphysema. So what assessment findings would lead you to suspect a tension pneumothorax, and why am I even bringing it up? Well, because with a pneumo, if air continues to collect, and it's taking up a lot of space like what you see here in this picture, then that air is going to take up the space that should be occupied by the lung, which is grabbing O2 from the air, and it's going to begin pushing not only the right lung over to the left, but, you know, all of those things, the structures, the vessels and heart in the mediastinum, it's going to push it over. Now, this can be a bad thing because as the heart and great vessels are getting pushed over, it is very hard for venous return to the heart, and so therefore the cardiac output can go down. It's actually very hard for the heart to fill with blood and eject blood, and so your cardiac output can markedly go down. what are you going to see? Well, you're going to see tracheal deviation. So you can see, you're not going to see this picture because this is the inside view, but you can actually see the trachea kind of being deviated or being pushed over to the opposite side. And then in addition to the absent breath sounds on the right, and perhaps the sub-Q emphysema, you're going to see tracheal deviation, and you're going to see signs and symptoms of poor cardiac output, which is the same as signs and symptoms of poor perfusion. If you're not sure what signs and symptoms of poor perfusion are, then email me. So let's talk about the process of a chest tube being inserted. It is a sterile procedure. And I've got some pictures here of chest tubes themselves. You can see that there are eyelets or holes at the end. And this is the part that's supposed to go in the patient. And then the inside of the tube, just know that it can be coated with heparin. Not all tubes are, but some are. And so that's because if there's blood draining out of it, we don't want stuff to clot. Now, smaller sizes can be used if the patient only has a pneumothorax and only air needs to be moved. Can you have a hemopneumothorax? Well, of course, you can. The more the merrier, especially in these trauma patients. So you may have tubes on the top of the chest and towards the bottom of the chest. Where are you going to put them? Well, obviously, it's a problem with the chest, so it's going to be on the chest wall. And specifically what intercostal space is something that whenever you go to medical school, or if you go to medical school, you're going to learn how to insert a chest tube. It's not something that you have to worry about as a nurse. Usually, if it's a pneumo, it's the top part of the chest, and if it's a fluid-filled problem, then it's the bottom part, because that's a gravity deal. As always, perform a pre-procedure assessment, medicate, positioning, supplies, equipment, consent, on and on. And then as the tube is inserted, well, obviously you're going to monitor your patient, and then you're going to manipulate and manage the chest drainage unit. Now, I don't think it's important because you're not going to be tested on, I don't think, the specifics of the chest drainage unit setup, but, you know, you should see it in the Smart Hospital on that first week, or if you're an online student, hopefully you'll get to see it in the hospital itself. Post-procedure stat portable chest x-ray. Why? Because the physician needs to make sure they actually put it in the space they intended it to be. And horror story where a physician, an inexperienced physician, actually put the chest tube in the right atrium instead of in the pleural space. That's never a good thing, and that's why you need to make sure that not only is your x-ray taken, but you post-monitor your patient, post-procedure assessment, and make sure that that chest tube is read by the physician. Position the patient for optimal drainage. Well, what does that mean? Well, 30 to 45 degrees if it's a pneumo, because, you know, air is going to rise, so it's going to be towards the top. So it's not really too important on the height of the bed. But then if there is fluid and blood, then you want to have them in a little bit higher Fowlers, so you help gravity, and that's 60 to 90 degrees. When we talk about chest tube insertion, again, what's the whole purpose? Well, we want to remove airflow or blood and then prevent the accumulation and re-expand the lower lung and restore negative intrapleural pressure. These are things that we already identified, but I want to point them out again. So what about the chest drainage unit? How does it help achieve those goals? So as I talk about the chest drainage unit and its various parts or components, then hopefully this will make sense to you why the chest drainage unit has the parts and pieces that it does, and what you, the nurse, need to do about these specific items. So again, we're going to link the A&P, the patho, with the actual chest drainage unit. Now, there's a bunch of different chest drainage units, and some of them are listed in the course document. It's not important that you know. There's brands, Atrium and Oasis, or Atrium and Pleurovac, that are the most common. It doesn't matter the brand. The bottom line is that all of them really work the same. They may work a little bit differently, but they have the same components. So what's one of the most well, I would say the most important part, is the air leak monitor, otherwise known as the water seal chamber. And so you can see on this chest drainage system, it's identified as C. So you, the nurse, you're going to have to fill this chamber with water. Why? Because as air leaves the patient, so again, it's hard to see, because this is kind of wrapped around and it's not connected. But you can see the chest drain. This is the piece that's going to connect. This end of this that's hidden behind the drain is going to connect to the actual chest tube that the physician pushed into the patient's pleural space. And as you can identify, the whole point is for stuff to drain out of the chest. But the big key is that we don't want stuff to go back in, especially air. It's probably going to be hard for fluid to go back in, but we don't, air, you can't see it, you don't know. We want that air to come out. And this water seal does exactly what it's supposed to do. It traps or seals the water so that it doesn't re-enter into the patient on inhalation. The other thing you might see, and that's this chamber here, it's connected to the water seal, is that if the patient's not on suction, you will see what's known as tidling. In other words, this blue water will go up and down, like the tide in an ocean. And it does that in response to the patient's breathing pattern. So it'll go up and down as the patient inhales and exhales. Now, you won't see tidling if the physician has ordered suction. So to assess for tidling, which you're supposed to do, then you all have to turn off the suction. You also won't see tidling when the lung is healed. So in other words, tidling is normal when it's present, but it's not abnormal if not present. So, it's one of those, maybe, maybe not. Now, as far as the air leak monitor, the reason why it's called the air leak monitor is because if this air leak monitor is constantly bubbling, then that means there's an air leak. And you can see it's kind of like the bars on your phone where it's got 5, 4, 3, 2, 1. And you may see an occasional bubble pop on in there if the patient's exhaling some air. But if you see continuous bubble, then you have to think of an air leak. Now, I have this to kind of show you how this water seal works, because it is very, very important. And so if you watch this O2 circle, this is meant to represent up here where the O2 is, the patient breathing. So air enters, O2, atmospheric air, enters the patient, and then goes down into the lungs. The lung here is damaged, and therefore it exits. That's the inner tube. That's got a leak, so air exits, and then that air is supposed to drain into the water seal, and then it will eventually make its way out in different manners depending on what kind of chest drainage device you have. So the big key is if you don't have water seal, that means air that's going to exit from the patient is going to re-enter into the lungs, and that can cause a pneumothorax. So I've had a surgeon tell me, you know what, if this thing breaks and you lose water seal, regardless of the type of device, put the end of the chest tube in a coffee cup. We'll worry about infection later. The last thing we want is for that patient to suck in air and then get a tension pneumothorax and have a problem. So again, water seal, super important. Now, the next thing we're going to look about is probably what takes up most of these chest drainage units, and that's the drainage collection chamber. So obviously, if you're the nurse, you want to measure the drainage, look how much is being removed or is draining out. It will depend on your patient's acuity on how often you assess the amount of drainage. The character, obviously, if it's fresh trauma, fresh surgery, you're going to have more bloody drainage. And then as the days progress, you're going to have serosanguinous and then just serous. You want to notify the healthcare provider for excessive output. Well, what the heck does that mean? What's excessive? Well, the course identifies that excessive may be anywhere from 100 to 200 mils per hour. You know, every hospital physician's going to have a definition of excessive. In this part of the exam 1 with chest tubes, it's really not identified what excessive means, but if your chest drainage was 50 mils last hour and then now you have 150, that's a lot. And then I would assess the next hour, and if you continue to have more and more, then that's something that you need to make sure you notify the physician. You want to ensure that the chest drainage unit is below the patient's chest for obvious reasons, gravity and removal of stuff in the lungs. And then you want to make sure that the drainage tubing, which is rather long, it's probably at least 4 feet long, has no dependent loops. And I want you guys to email me if you don't see dependent loops on the hospital units. I always see them. You want to make sure they're free of obstruction. All of these things, the no dependent loops and free of obstruction, ensure that the chest tube does what it's supposed to do, which is remove the air-blood fluid. Milking or stripping a chest tube. This is an old term that we dinosaurs will use. I don't know if you'll hear about it, but of course it's on the notes, so it could be on the test. So what does stripping means? It means that we used to grab the tubing, starting actually at the chest tube that's outside the patient, and then move all the way down the chest tube tubing and kind of pinch it and then pull down on it. And that was supposed to encourage chest drainage. The problem with that is anytime you crimp it or seal it or softly clamp it, you have the potential of causing damage to the patient as far as their pneumothorax reduces or can cause the pneumo to worsen or cause a tension pneumo. So don't do it. It's recommended that it not be done. And, a lot of nurses in the olden days did it because there would be blood clots, and so they were trying to break up the blood clots. But the newer chest drainage tubing, it's heparin coated, and so I haven't seen clots as a problem in a long, long time. So that says to you, well, we shouldn't be clamping, crimping, stripping, whatever, the chest drainage, except, of course, this is why I always think it's a testing kind of thing, except in a few scenarios. So you can clamp the chest drainage when you're replacing a full or broken chest drainage unit. And this makes sense. I mean, you don't want air to go in the patient, so it's not like you would disconnect at the chest tube and then go, okay, breathe a whole bunch, patient, and have air re-enter that chest. I mean, you would want to clamp that chest tube and then remove the tubing and then get another one and then immediately unclamp it. So, you're going to do it for seconds. You should have everything ready to go. Troubleshooting from an air leak. In other words, if you see continuous bubbling down here, well, where's the bubbling? Where's the air leak? So you're going to have to problem solve from the insertion side all the way down. And so some people will clamp to see, is it here, here, here? Again, it's very quick clamp, unclamp. And then sometimes physicians will have the nurses clamp the chest tubing at the drainage site because they're checking to see, well, how well is the patient going to tolerate the removal of the chest tube, and this is a great opportunity to see it. So that's on physician or a healthcare provider prescription. All right, our last chamber is the suction chamber. And again, you can see I'm looking at this whole piece right here, A and E. And so there are two different kinds of chest tubes. There's a wet chest tube and a dry chest tube. And the difference is that in the wet, water is used to apply suction, whereas in this chest tube, which is a dry, water is not used for suction. I haven't seen a wet chest tube, I don't know, in 10 years. However, I have been told by some of the fellow faculty that some hospitals nonprofit hospitals or county hospitals may still have the wet, cheaper chest tubes. We're going to talk about the dry chest tube because that's what this one is. So the suction level is, the amount of suction is at A. So you can see with this one, if you can kind of read between that red line, it's at 20 centimeters of water. And then the red bellows is here, and so it indicates that your suction is on and working. Now, what about suction? Should the patient be hooked to suction? Well, it's a physician prescribing thing, so that's number one. There are pros and cons to both. To suction is believed that it will expedite the removal of air out of the pleural space and can help pull the lung up against the parietal pleura. However, some say, no, you really shouldn't do suction because it could actually prolong the air leaks from the lung. And so, I've seen it both ways. I think it's really all about how has the healthcare provider been trained. And so that kind of, because it's a maybe, maybe not. Now, this is a picture of a wet suction. So you can see, if you go back to the other picture, that there's an additional chamber to the left. Here's your water seal. Here's the drainage. That's pretty much standard with everything. And then here is your wet suction. So you would fill up water in the suction chamber. Now, I think the biggest, and then you're going to hook it to suction, and then this suction chamber will continuously bubble. Now, the biggest key for you is testing, warning, is that if there is constant bubbling in the suction chamber, that's normal. But if you're being asked about the water seal chamber, a totally separate chamber, that is abnormal for constant bubbling. So don't get fooled on the test exam questions, whether it's NCLEX, ATI, or critical care. All right, so let's look at what are the complications and the nurse's role. And this is where I really deleted and did a lot of abbreviated information. Again, assessment pre-chest tube insertion, during the chest tube insertion, and after the chest tube insertion is important. You really should read the article or the document, the course document, if you have no idea how to assess. I think you do, and so that's why I dumped it. I'm going to really focus on the biggies, on the complications and what you do about them. But, because of my disclaimer, I have to say, read the entire course document because you don't want to be without too much information. All right, let's talk about chest tube malposition. This is one of the complications that can occur. So, how do you know if your chest tube's malpositioned? Well, we're going to start in the beginning. Once the physician puts it in, you get that physician to read it to make sure as far as is it in the right place. So that's where you start there. But as far as nursing assessment goes, you're going to start at the insertion site on the chest, and then you work your way down on the chest tube and then down the tubing to the chest, the CDU, chest drainage unit. You want to check for air leaks. We talked about that, constant bubbling in the water seal chamber, and make sure that all connections are intact because you've got a chest tube that's inserted by the physician, and then you hook up the chest drainage unit to that chest tube. And if you don't have a good seal on that, most nurses will actually tape the connection, then you can get an air leak. If the patient kind of slightly pulls the chest tube out, so that's if the eyelids, you can see them, then they're not in the pleural space, and that's where they're supposed to be. The eyelets are there to drain out air blood fluid, and if those eyelets aren't in the pleural space, then there's a problem. And then that also means that because that patient, there's a connection between the lung thoracic space and the subcutaneous space, then that patient's going to form a lot of subcutaneous air, and you're going to feel that crepitus that we already talked about earlier. If the chest tube becomes disconnected from the CDU because the nurse didn't tape it well or ensure that it was put together, well then, you need to reconnect it. If the CDU, chest drainage unit, is cracked, damaged, then you need to replace it. If it falls over, set it up right. And then again, check for titling that we've already talked about. And remember that titling does not always have to be present. If it's not present, then there's some good things that can be occurring. So go back and review that if you're not sure. If the chest tube is partially pulled out, assess the patient. You need to immediately call the healthcare provider, because if there's air that's being re-entered into the patient's chest, we've talked about the risk is a tension pneumo. So that's almost the answer to a lot of questions. Tension pneumo is the risk. And the reason why is because it's life-threatening. If the chest tube is completely pulled out, because, yes, I've done it before, the dopey nurse hooked her foot on the tubing and then just pulled the whole thing out. You got to assess the patient, call the healthcare provider, and then you may or may not cover the site with dressing and tape on 3 sides. You don't want to ever, 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 if there's a hole in somebody's chest, put tape on all 4 sides because you don't want a tension pneumo to form. If there's a hole in the chest, exterior chest wall or external chest wall, and the patient inhales, air is going to go in. And then when they exhale, then that air may be able to escape or it may not. So that's why it's always tape on 3 sides. It's still an emergent situation, and you have to assess for worsening patient scenario because of a tension pneumo. Some other complications, site infection, isn't that always one of the options? Pneumonia, because it can either occur because it could have been the original problem, or it can occur because of immobility. Vasovagal means that something has caused the vasovagal, or the not vasovagal, but the vagal nerve to be stimulated, and this can cause a sudden drop in the heart rate and blood pressure. And patients can actually faint or have a syncopal episode or pass out, or they can almost feel like they're going to. And this vasovagal response can occur because of the rapid removal of the intrapleural fluid. So vasovagal can really happen to a lot of people, especially sometimes when they're just in pain. But that's what you're going to see, heart rate and blood pressure decrease. Vasovagal, the reason why the nerve is called vagal nerve is because it wanders all over. So it's found in a bunch of different places, which means it can be activated in a bunch of different ways. Re-expansion of pulmonary edema, I've never heard of this, never seen it. Evidently it must exist because it's in the notes. This can happen following rapid expansion of a collapsed lung or evacuation of large amounts of fluids. And then there's shoulder disuse atrophy. Chest tube hurts, and if that chest tube is kind of like in the axillary area and it's high in the chest wall, then that patient's not going to want to move. So if they don't want to move that shoulder, then they can get shoulder disuse atrophy. So you, the nurse, should do passive range of motion. To me, it sounds like you need to contact PT, and that's something that they should do because you have a lot to do already. When should the chest tube be removed? Well, really, that's a healthcare provider decision. The nurse is going to assess, and you can report what your assessment findings are, but it's up to the physician. And again, if it's once the chest tube is removed, then you want to make sure that you assess the patient, because if the patient's not tolerating their chest tube removal, then they can go down in a hurry, and you need to identify that. So what are the process? Again, there's a lot of details in the notes, none of which I've ever seen on a testing scenario, but you can see there's sutures, blah, blah, blah. So really when you remove when the physician removes the chest tube or even a central line, the key thing is the patient should inhale deeply before the removal, exhale, and then stop breathing. Why? Because once air is removed from the lungs, then the patient's kind of in that 0 or lower negative intrathoracic pressure, and that will decrease the risk of air entering in either that big gaping hole in the side of their chest, or if it's a central line scenario, in the vein. Because you can cause the patient, if they inhale while you're removing a chest tube or a central line, air can enter, and then of course that can cause the problem that we were trying to get rid of, which is air in the pleural space. And then if it's a central line, they can have an air embolus. Mediastinal tube. So this is kind of a separate topic. So you can see here, it's not a really great picture, Google it if you don't like it, but here's the mediastinal space, and when individuals have cardiac surgery, usually it's a valve job on a cardiac valve or bypass surgery, so they do a lot of slicing and dicing on the exterior portion of the heart, and whenever that happens, then inflammation, because that's part of healing, can occur, and that will cause a lot of serous fluid to leak in this mediastinal space. And if that serous fluid leaks into this space, well, it's going to do exactly what air would do in the lung space, and it would take up space, which means the heart cannot Excuse me. The heart can inflate, deflate, which I'm talking about diastole, systole, so your patient can have a markedly decreased cardiac output and ultimate death. So again, mediastinal tubes are following any kind of heart surgery. They're placed by the surgeon in the mediastinal area, and that's underneath the sternum, and you can see they exit outside the body, and they're draining. Usually most nurses who have a mediastinal tube, they will mark the chest drainage unit that it is mediastinal, because it's very important to watch the output of that. Again, the purpose is to prevent accumulation of fluid around the heart, which could lead to, if the fluid accumulated, could lead to pericardial tamponade or cardiac tamponade, which is a potentially life-threatening complication. Now, the tubes aren't in the pleural cavity, so you're not going to see titling in the mediastinal chest drainage unit. And you're not going to see, obviously, the suction would be the same. Anyway, you're not going to see titling in the chest. You do need titling. Again, let me rephrase that. You do need a water seal still in that chamber, because even though the patient's inhaling, we don't want whatever has been out from the CDU, from the mediastinal fluid, we don't want it going back in anywhere. So, you just keep that tidal, the water seal intact, but you're not going to see titling. You need to assess for drainage. It should be somewhat consistent, a lot in the beginning and then less and less. But if it suddenly stops, then there could be a kink or a clot in the tubing. And again, if it's not draining, then it's collecting in this mediastinal space, and the patient can have cardiac tamponade. I hope this has been helpful. If you have any questions, email me. Again, I've given you the link here of the YouTube video that talks a lot, mostly about, it's by the Pleurovac or Atrium people, so it's really about the chest drainage unit. So again, inquiring minds, you may want to look at it. I haven't seen questions about the chest drainage unit itself. It's mostly about the patient connection. So I will answer any questions that you have.